I am a Ugandan. I'm from Uganda, and I am a student of Uganda Christian University, the main campus, and I'm pursuing a bachelor's of social work and social administration. I'm in my first year and hoping to join my second year in January next year.
Thank you so much, Peace. I want us to go direct to Delphine.
Good evening, everyone. My name is Delphine. I'm Rwandan as nationality. I am a social work professional, medical psychiatric social work as specialty. I'm working as medical psychiatric social work in Rwanda at National Psychiatric Hospital at Karayesi Ndera, and I have 5 experience of working with psychiatric patients, their parents, and their families also. Thank you.
You're welcome, Delphine. Over to you, Ndahiro Bright.
Yes, thank you for allowing me. I'm Ndahiro Bright, a student of Kavala University in Uganda. Currently, I'm in my second year, pursuing a Bachelor of Social Work. Hoping to join third year this coming January. Thank you. And I'm a Ugandan by nationality.
Wow, good to have you all, guys. And it's lovely being here for our discussion today. My name is Branley Madati, a Tanzanian professional. I'm a mental health therapist working with an organization called Cornerstone Development Africa, which has its operation in all the 7 East African countries. And I'm so honored and privileged to be your moderator today. And without wasting time, we want direct to go to our discussion today. And I will kindly encourage us to keep time. Our first item will be on discussing suicide and its prevalence in East Africa. And I want to invite Peace Kirabo in about 6 to 7 minutes to expose this topic. Over to you, Peace.
Thank you, Bradley. Prevalence, that means, according to research I made, it means commonness. How common is this suicide thing in East Africa? And as seen, it is mostly common in youth. It's common in young people, mostly in the age of 14 and 20 something, because that is the age that where those kind of people in pre and adolescence have a lot of thoughts, or they are facing a lot of challenges, and they think the only way to do or to get away from all the problems they are facing is through committing suicide. This is common because in 2014, the World Health Organization started a force was focusing on mainly stopping that thing, and by 2000 by then the percentage was 75%, and then when they focused on the issue, it kind of got a success or a goal of 10% by the end of 2020. That is 2 years ago. So the thing is still going on, and and we are praying for more results and more positive results. And also, the population of most of the people that were committing suicide was 800,000 per year. So yeah, it is really common in students, as research suggests, that mostly students, because they are in influence of other people and other age mates, they commit the suicide because they think at some point they are bullied, or they are facing some challenges, or they are kind of also comparing themselves to others, and they can't really reach that goal. So they, to make everything possible for them, they mostly think committing suicide is to dull the pain and to make everything look a little bit easier, because they think maybe heaven is the best place, which I don't think. When you commit suicide, heaven is, yeah, the place. Thank you.
Thank you so much, Peace, for being precise and giving us some of the accurate data about the suicide tendencies, especially in East Africa. And without wasting time, I want to invite the Hero Bright to tell us the factors contributing to suicide in East Africa. Over, it is not connected. We cannot hear you. Oh, yeah. Please go ahead. You have about 6 minutes to tell us the factors contributing to suicide in East Africa. Over to you.
Yeah, thank you very much, Modulator Madati. And me coming up to explain about some of the factors contributing to the suicide or committing suicide by the young people in East Africa. So without wasting much of the time, I go straight to the point. One of them is gambling as one of the major factors that is contributing to committing suicide among young people. Mostly this is between the age of 15 and 24 years. In this age bracket, we are finding very many people where they are students, adolescents, and they are having a lot of peer pressure, where they are, for example, at the beginning of this week, we had one of the cases about one of the students who has committed suicide, was given a tuition of 2 million Ugandan shillings to pay in the tertiary institution, but because he wanted to make more profits, and now this money was choked, he did not get any interest and any return, and at the end, he had to end his life because of that. So gambling has been one of the main factors which has caused most of the people in East Africa, mainly between age 15 and 24 years, to commit suicide. And another thing, it is drug addiction and abuse. And this is mainly common between ages 16 and 22 years. It is common amidst those years. So drug addiction and abuse as another factor. Here, we are finding people in this age bracket, they are having a lot of peer pressure, they are having a lot of influence, and most of them, they are trying to test each and every kind of drug, alcohol, take marijuana, take opium, all those things. And now it is intoxicating their minds, hence leading them to feel that they have this life, even there is nothing that is within, is possible with this life. So at the end of it all, they think of it is ending their life because they think they have no other option and they are useless because of the influence of drugs. So drugs have been another challenge or another contributing factor to committing suicide. And another point is like where we have depression. Most of these young people, possibly mainly between ages 17 and 25, those age bracket, in that age bracket of 17 and 25. Here we are seeing most of them, they face depression. Why? Because most of them have begun into some relationships, some serious relationships, and now at the end of it all, one of them is either chucked, as people say, or is dumped by boyfriend or girlfriend, and these people thought this is boyfriend and it is what I have. So they spend all their time, they think of them that they can take care of them. At the end of it all, when they are dumped down, their hearts are broken, and at the end of it all, they face a challenge of depression. When they go into that depression and they don't get any help, you find that their mental capacity or their psychology tells them the other reason now is to end your life, because there is nobody that loves you. Because when you are depressed, you think nobody loves you and nothing you have to do in this world. In the past 2 days, right?
And you have 1 minute to conclude your presentation, please.
Yeah, thank you. So I was in the point of depression where one of the girls of 16 years now was like, I'm crying, a boyfriend has just left me, so nothing else. I feel the world is ending upon me. I have nothing to do into this world. So that reason, when this depression increases, it will force this young child to commit suicide. And lastly, a failure in academics. This is most especially amidst the candidates and students at the university, where if they fail in their academics, they think there is nothing else. And some other, even like parents, they tell them, surely if you have failed, then you are useless. So because of that thing, because of those words, and they feel that they are rejected, there is nothing they can do into this world, they end up committing suicide. Like an example, previously, a young child of P7 of 13 years, a young girl, committed suicide in one of the districts in Uganda after receiving her results when she had failed. I thank you for all and listening. Thank you very much.
Thank you so much. And the hero of that was precise, and it's full of the recent information, especially from your side in Uganda. So without wasting time, I want to invite Jelagat from Kenya to tell us what can social workers do in suicide prevention, the role of social workers in suicide prevention. Jelagat, you have 6 to 7 minutes to submit your presentation. Over to you.
Good evening, everyone. My name is Mercy Kimayo Chelagat. I'm a social worker working at the mental health department. What I'm going to discuss today is about the role of the social worker in strengthening prevention of suicide. And I have few points. One of them is strengthening the economic supports. I'll just go point into point so that we save on time. One of the things is strengthening the household financial security. The second one is housing stabilization, or providing the houses, what are the policies that we have that can support our clients to have the housing factor. The third one is to strengthen the financial, we need to introduce the chamas. In Kenya, we call them chamas, but these are the table banking where we come in to put in our money so that at the end of the month, we are in a position to share this money and can bring in sort of a social interaction within that group. The second one is strengthening the access to delivery of suicide care. How do we strengthen the access to delivery of suicide care? One of them is coverage of mental health conditions in health insurance policies. In Kenya, we have something that we call NHIF, that is National Health Insurance Cover. How do we ensure that our clients get to know that I can go to the hospital and use my cover or the health insurance to get treated? Number two is reduce provider shortages in underserved areas. We have villages where the doctors cannot reach, but as the social workers, how do we ensure that the clients down at the village are being served. How do we get to ensure that we do the sensitization to the facilities and even the social workers at the rural facilities so that we get to support our clients from where they're coming from? The third one is safer suicide care through systems change. This is more of a stigma, unlike telling our clients, even you the other day you wanted to commit suicide. How do we support our clients, those who attempted suicide, to support them and like give stigmatizing them? Now, other one is about mentorship of facilities. How do we bring out our social workers to mentor the facilities at the rural settings to be seeing the clients, especially with the mental illness, and for those who have had suicidal ideations. Now the other one is empowering the police or the police/legal department. Mostly in Kenya, when someone attempts suicide, most of them they are detained at the police cell. But how do we mentor or sensitize the police that once someone attempts suicide, instead of detaining that person, bring that person to the hospital and like detaining them, and they can come to the hospital for care. The third one is creating protective environments. This is reducing access to lethal means among the risk population. These are things like the guns, like the, for instance, mostly people would use poison. How do we get to safeguard these things? Another one is organizational policies and culture. How do we, as social workers, help in policy making, especially things concerning suicide? Third one is community-based policies to reduce things like substance and policy use. How do we make use of the chiefs in our communities to empower them to reduce the intake of substances and intake of the alcohol? Another one is promoting connectedness. These are peer norm programs. How do we have peer group programs within the community? How, as the social workers, can we start these peer norm programs where we can have, even, let's say today, football game, volleyball, that can bring the youth together, that can bring a peer group together, and that can reduce or prevent the suicide because they have an activity that they are working on. Another one is community engagement activities. How do we support the community? We have the cleaning programs. We have even visiting the children, children's homes. We have even helping the poor. How do we engage these people so that all the time they have one of the community social responsibility? We also have the teaching coping, let me put it as coping stroke problem solving skills. How do we educate the people outside there, the clients, on how to solve the problems? Initially, you could say, today I don't have sugar in my house. How do I go about it? I don't have money to buy the sugar. But again, at the same time, I can I can take this without sugar. How do we empower them that some things are not a must to have and some things we can do away with them? We can prioritize our needs. We start with the basic needs as we move to other needs according to whatever we have, unlike them having everything. Another one is identifying and supporting people at risk.
You have 1 minute to conclude, Gilbert.
Okay, identifying and supporting people at risk. How do we support them, encouraging them and bringing them closer to care? The last one that I would put is how do we support the survivors of suicide? Because probably someone has died of suicide. How do you support the family or the survivors? By referring them to a psychologist. I think that's from my end. Thank you.
Wow, thank you so much, Gilbert. That was so rich. I mean, I wish you'd have more time to share with us your views. And lastly, I want to bring on stage Delphine, and Delphine is going to share with us what should be done at the micro, meso, and macro level of intervention in social work to prevent suicide in our community. Delphine, you have 6 to 7 minutes to bring in your submission. Over to you, Delphine.
Okay, thank you. Good evening, everyone. First of all, I have to present and to highlight suicide. Suicide is considered as a major public health problem around the world. where 10 million of people around the world affected by severe depression, and 50% of them will commit suicide. This shows that it's a big global issue. Every 45 seconds, about 1 minute, someone is commit suicide somewhere in the world. This shows how depression is a psychiatric pathology or mental disorder, which is accompanied by suicide. But other mental disorder like PTSD, drug abuse, bipolar disorder, and schizophrenia, those pathology, those psychiatric disorder marked by a high risk of suicide. I want to share you the case on Rwanda specific as my country. In Rwanda, since 2019 to 2021, there were 579 cases of suicide. In this year, in 2022, there were 288 cases of suicide. According to statistics done by Rwanda Investigation Bureau, that means that one person in Rwanda every 30 hours, one person is dying by suicide. This means that there is extremely alarming of suicide. That 5% of survivors of Rwandan genocide presenting severe depression that can accompany by suicide. 26% of Rwandan population present PTSD, post-traumatic disorder, because of result of genocide. But 5% only for those people are looking for treatment. You can imagine on that 5% and the 26%, only 5% looking for treatment. How there is, what those high risk of those cases? There are some domestic dispute, family conflict, psychiatric illness, family history for psychiatric illness, some divorces, and the economic crisis also. Then let me come back on the question you ask, what should be done at micro level, meso level, macro level on intervention work to prevent suicide in community. There are many things that we have to do. Firstly, we can increasing awareness. How to increase awareness? There is training for people for raising awareness in community. When people doesn't know those psychiatric illness, what is depression, what is PTSD, how those people affected, those symptoms of suicide, they cannot do anything without raising awareness. Also, education of general public, including medical, government website, posting information about suicide. Because if we discuss that there is a suicide in the world, we have to raise awareness and educate general public and to post information about suicide. Also, chemotherapy, if there is any psychiatric illness, screened. When doctors or social work psychologists, when they screen those psychiatric illness, those people can have chemotherapy, also psychological support. Also, there is psychoeducation and psychotherapy according to finding from complete medical assessment. When there is medical assessment to those psychiatric illness, also they have to be psychotherapy, even psychoeducation in community. There is another thing, working with local authorities, how to work with them for reaching out of the families for education about high risk of suicide. When those local authorities, they have to reach easily for the people. They have to communicate for the people. When those people have opportunity of working with local authorities, those families have psychoeducation of high risk of suicide. Also increasing of capacity of health center by the increasing of capacity of health worker and equipment for helping people with symptom of suicide. There are people who doesn't know even the symptom of suicide. I was talking about.
You have 1 minute, Delphine. You have 1 minute to conclude.
I am talking about family conflict. In the conflict, maybe they have symptoms of suicide. Yes, we have to educate those people. The last three is to educate teachers, parents on how to identify students who are at risk of suicide behavior. Thank you.
Thank you so much, Delphine, for again such a rich and precise presentation. Thank you for accurate information. And as I said earlier, I feel we probably needed to have more time for each one of us to say what they have. But we quickly want to have an interaction, all of us. I have had Jilagat sharing from the Kenyan perspective, and it looks like there's so much mental health awareness in Kenya compared to other countries. I've had Delphine, the Hilo, and Peace. So we just want to have Q&A interaction, and I would wish to see these questions coming from ourselves. This question coming from ourselves. If you have any question from another panelist, maybe they said something from their country perspective and you want to give your views or to ask questions, please, you can go ahead. Just raise up your hand and ask, or you can use the chat bar to ask. And I'll also have few inputs. We have about 13 minutes to finish our call. So please, if you have any question or suggestion that will open up our minds more and more, please just come in and ask your question.
Let me put through something. Just an example of what I've been doing. Whenever I go for a home visit, especially here in Kenya, I don't just do a home visit to that family. I invite for a baraza or people coming in. Like I request the chief to have many people coming in so that I use that opportunity to teach on mental health. And that's what I've been doing and screening mental illness. And that helps me in terms of referring clients and supporting that community in terms of sensitizing about mental illness and also helping them support this client that I'm either repatriating or going for a home visit. So one of the things that I would suggest is whenever we go for a home visit, let just not be a home visit to that family. Let it be a community home visit stroke sensitization.
Thank you so much, Jilagat. I think I have one question for all of us, the panelists here. I'm a mental health therapist, as I said earlier, and one of the greatest challenges that I personally have been facing is when you try to educate people anything regarding mental health. Sometimes, Jilagat, please, if you don't mind, please mute your microphone. Thank you. So I was trying to say that in most cases, especially in our African setting, when you try to educate people in things to do with mental health, things to do with suicide, they always find it like this is not our thing. I've heard some Swahili phrase that people use to despise or to discourage people who are into mental health, helping the prevention of suicide and other mental health challenges. So I want us to quickly give our thoughts. How relevant have we been into trying to not being discouraged and trying to continue reaching out to people and helping them. What have you been doing in your capacity to help people in trying to prevent suicide in our communities? Anyone who wants to respond, maybe Peace or Delphine, you guys have been working in different places, maybe in the Hero. Just a quick response. Yes, Peace, go ahead.
Well, me as a Christian, I'm a Christian by the way. So most of the times we try to like bring people to Christ, and then as like in that way, when you bring people to Christ, they kind of like, of course, God is going to wipe away all the depression and the stress, but then they don't see that, so they kind of hold back from coming to church or gatherings or fellowships that are really helpful for them. And then they still stay in their depressed states and their stressful lives, and then the options are really not that good. Yeah, that's all I have to say. Thank you.
So to respond on that question, most
Yes,
of our African setting believe mental health is not there. One of them, they feel like it's more of witchcraft. It's more of taking someone's items, and they more believe on human chemistry or magic, or going to a muganga or a witchcraft. So one of the things that I usually tell them is I usually probably bring in the example of an existing person that was not functional in the society, and now they are functional in terms of doing things on a daily basis. Number two is there's an issue of Christianity. I usually tell my clients, yes, I agree that we are going to pray for these clients, but let the prayers work with the medicines. Let's work hand in hand with the medicines and the prayers, and minimize going to the muganga or the witchcraft person. Yeah, so I try as much as I can to sensitize them and tell them this is the disease of the brain. Like the way we have a disease of hypertension, disease of the heart, this is the disease of the brain. And like brain is any like other parts of the body can get sick. So this is majorly the brain alone.
Thank you so much, Gilligan. Before inviting Ndahiro, his hand was up. I'm also a believer, but one thing I have continued wanting to be careful is how, as a social worker, you can reach out to people without appearing to be biased on what they believe on or what they don't believe. So, how I pray that we continue learning interventions. You know, I'm a Christian. I may have a client from a Muslim background, and I need to help them without caring what religious background they are coming from. So this is another aspect that we should learn. We should really equip ourselves with enough knowledge that will help us not to appear judgmental or not to appear biased, because you will not always have people from your faith. But I also love what Gilligan said. Sometimes people believe in prayer. I do believe in prayer as well, but believing in prayer does not mean suppressing or undermining the scientific data or the scientific facts that are there to help us overcoming the situations that we are in. It's not that everything requires prayer. I mean, I've had clients who come and say, pray for me. Okay, I've been happening to work in a Christian setting. Pray for me. This is not happening. And when you listen in, you realize that what they are facing just needed a talk therapy or needed you to do some timeline to help them get out of that situation. So let's be careful on balancing this equation so that we don't appear to be biased. Quickly, I want to give the microphone to Ndahiro in less than a minute. Please go ahead and tell us, what do you think, as we are almost going to conclusion? And if Mayaka and Gerard, you're in the call, as we're about to conclude, we'd also love to hear your submissions about the conclusive remarks about our panel today. Over to Ndayo, just a minute, then we'll be concluding.
Yeah. Thank you very much, Madati, moderator. Mine about that question that you have asked, how we can handle or how we can help people who are facing suicide challenges. Mostly, I got some of the challenges previously. I have been in a holiday, and one of my neighbors wanted to commit suicide. As you have just elaborated, most of them need just a talk therapy. I talked to this man, wanted to commit suicide, that the wife is just disturbing her, doesn't want to sell things, just minor things. I told him, you man, what you need, you have a lot of things to do. You still have children to cater for. So in that, you don't need to commit suicide as the way that you want to live with this wife. No, that is not the way. So most of them need a talk therapy, and others need just having a follow-up on them. Not only forcing them to do what, telling them that this can be done. Only what we need to tell them, you have to speak to them, tell them you have a lot of things to do. If the challenge is not all that bad, or some of the reason that you want to commit suicide is not all that strong, you have to talk to them, encourage them, and emphasize to them that suicide is not the best way to do, or the best way to end the problem, but you have to solve the problem by facing it. Thank you.
Thank you so much, guys. I've received one question from the live chat, which I was trying to follow up on Facebook. I want to ask us to respond to this question, then we'll be concluding. Someone is asking, in a country like Tanzania, where victims who try to commit suicide face government charges, what do they have to say regarding that law? Jelagat shared something on this matter, and I would be glad to hear you telling us. In a country like Tanzania, which I think is the same to Kenya, you might find someone was so depressed and they try to commit suicide. So what do you have to say about this law? Do you think this law is fair, and what can we do to undo the law that wants to jail people who wanted to commit suicide? In less than a minute, over to you, Jelagat.
So let me first respond by correcting. We are not committing suicide, but attempting suicide or die by suicide. When we say committing, it's a crime that we are doing. That is why the law allows someone to be convicted or something like that. This is dying by suicide or attempting suicide. So one of the things, especially in Kenya, that we've done is sensitizing the legal department, the police officers, not to, for instance, detain these people and bring them to the hospital. For instance, like in our county, what I've done is giving out my number so that anytime they find someone, they can call us or give out a hotline number. So for Tanzania, what you can do is, especially the social workers, be on the forefront in terms of championing for the rights of these clients who wants to attempt suicide. Let's not leave them. Let's speak out our voice. Let's always be there for them, and let's stand firm for them and support them and bring them for care, and like checking them to the police department.
Wow, thank you so much, Jelagat. I wish we have more time to interact and learn from your experience, and I hope we can have another engagement out of this one and like get to learn again from you and others. So thank you guys for being here. The last item that I want to say before welcoming Mayaka is never undermine that input you may have towards helping someone's life. You know, sometimes I've seen what disappoints or discourages people is, I'm trying to help, nobody's not seeing, nobody's supporting, but I really I've always wanted to measure in that input, that little input I can have towards helping someone to have better life. And altogether, especially at the micro level of intervention, we have a role to play in making life better. It was good to have you here. Mayaka, you have 2 minutes to say the conclusive remarks, and we'll be concluding for today. And thank you for working hard to make it happen.
Brothers and sisters, I want to take this opportunity to present my sincere appreciation for the wonderful reflections and thoughts that you've shared with us. Indeed, mental health and suicide is a subject that we have to tackle on a daily basis. And we have a role as social workers to ensure that we promote community well-being at all levels. I would just comment briefly on the question that has been shared. Most or in a well-developed governance, you'll find that mental health is treated as a medical condition. And for that reason, we as African young people, we need to advocate and spearhead the policy making so that it can be changed not to be treated as a crime rather than a mental or a health condition that requires health approaches. So anybody cannot just come up and decide to commit suicide. Otherwise, everybody could try to commit. As Chelagat mentioned, it is attempting to. And there is always a cause to that. And if we are able to tackle the cause, then we will be able to have played a key role in preventing any further attempt to suicide. However, every case has to be treated individually because there are those that might be because of criminal cases. If somebody is caught committing a crime, so is trying to cover or to escape, undergoing the process of justice or something like that, so they will be trying to run away by committing suicide. However, if it is a medical condition, it should be treated as a medical condition, and that is why we need, as professionals and particularly as young people who are in the community, social workers work with every individual in the community, and we live in this community, so we understand each case by case. We should be able to recommend, and let us take our position in advocating for a sustainable community whereby everybody is treated in a manner that he or she should be able. Otherwise, this is a subject that requires more time. However, because of some logistics and because of some challenges, we are not able to take it longer. We should be having another episode probably next week, which will be able to further these. So if you're able to join us next week, kindly join us and let us discuss, continue with the discussion, even as we celebrate the role of young people in contributing to community well-being. And this is just one of the subjects. So next month, we are going to also get into other subjects of importance to our life. And everyone, every young person is welcomed to join us. To that end, let me say thank you very much to everyone present here. Thank you for all those who are following us live on social media. We want to wish you the very best, and let us continue with the discussion. This is not the end of the debate. The discussion continues on social media. Let us continue asking questions, and we'll be able to get responses all through. To that end, thank you and be blessed. Have a nice weekend to all of you.
Thank you, everybody. Bye-bye.